Good morning, ladies and gentlemen. Ni hao. First of all, I would like to sincerely apologize for all of you that I cannot be here in person with you today due to personal critical problems. But I'm committed to this conference, so I come via video. I hope you agree with that. My presentation to you today is on human resource for health in the Southeast Asian country. I have 4 topics to talk to you. First, the factors that affect healthcare system. Second, the 4 challenges of human resource for health among ASEAN countries. And third, actions that has been taken in this region and actually around the world to tackle the challenges on human resource for health. And lastly, key success factors as well as conclusions. Okay? Now, start with the first one. We have at the moment at least 3 very big changes, dynamic of changes that affect healthcare system. I want to give you with example. I want to tell you with example. Nowadays, if you happen to have appendicitis, when you go to see the doctor, you are likely to be diagnosed not by question, physical examination, but you also need CT scans. And it's likely that you will be operated by laparoscopic appendectomy instead of normal surgery. If you have high fever, suspected of getting malaria, now microscopic examination of your blood may be replaced by rapid test. Tuberculosis is diagnosed by gene experts rather than sputum exam and acid-fast bacilli strain, like what we did long ago. New vaccines, new drugs are emerging every day, every week, every month. Cancer now are treated by targeted therapies, not only normal chemotherapy. Radiotherapy are very focused, very targeted. New vaccines like HPV, pneumococcal conjugated vaccine, rotavirus vaccine, and the latest one, dengue hemorrhagic fever vaccines, are emerging. And we are facing the challenges from organizations like Gavi, particularly ASEAN country. ASEAN country are now, most of us are now middle income country. Many of us are moving out of Gavi now. But because of Gavi, we are engaged with new vaccines. So when we move out of Gavi, we will not be able to purchase low price new vaccines from Gavi. We have to purchase high price on our own. Those middle income countries who are already out of Gavi, like Philippines, Indonesia, Thailand, Malaysia, these are the countries who cannot afford the high price of vaccine, but who are not within Gavi. How are we going to meet these challenges? This is the first challenges that affect healthcare system, technology explosion. The second one, aging population, urbanization, smaller families, international trade agreement, Trans-Pacific Partnership Agreement. All this will drive more trade in goods, in services, and in bads like tobacco and alcohol, which affect the control of NCDs. International Trade Agreement, particularly TPP, will also limit the capacity of the country, the government, to protect their citizens access to essential medicines. You have to buy higher price patented drug at longer period of time and with limited capacity to implement TRIPS flexibilities if you join TPP. How are we going to solve this? International trade agreement also means rapid movement of people, labor, capital, as well as human resource for health. How are we going to plan for our healthcare system with all these rapid changes? And lastly, epidemiological transition from acute infectious disease, which patients come to us once and treated and go back home, cure and never come back to us again. Now move to chronic condition and injuries and mental health, which patient will come to us many times. Imagine a patient infected with HIV/AIDS. They'll not come once and go back home and never come back again. They'll come and come and come and come 3-4 times or even 6 times a year. Diabetes, hypertension, cancer, these patients come 3-4-5 times or many times a year. Mental health, they don't come to us once a year. So these are big challenges. And if you are going to tackle them, you cannot tackle them with health technology. But they expect health technology to tackle this health problem. But actually, you have to tackle them based on social determinant of health. So these are the three, I would call 3 tsunamis that affect healthcare system seriously. It increases health investment. I would call health investment rather than health expense. The health investment is increasing faster than economic growth in most or all ASEAN countries. What does this mean? This means that the percentage of GDP on health is increasing. If you become richer, you spend more on health. If it is cost effective, it is okay. If it is not cost effective, you are spending money for less health. You have more money for health, but do you have more health for money? This is the challenge. Demand for health services will increase because of chronic condition and injuries and long-term care and health technologies with very much specialization. The more sophisticated health technology demand more specializations. A few examples for you. One example, just one. My maid got appendicitis. She was diagnosed by CT scan. After almost 24 hours, she get the appendectomy. If she went to a small hospital, rural hospital like I used to work before, she'll be diagnosed within 15 minutes. And within half an hour, her appendix will be resected. But in this case, she went to a tertiary care medical school with all the residents and specialists who has to depend on CT scan to diagnose her appendicitis and wait more than 24 hours to operate on her. Then what happened in the operation room? They also found 2 chocolate cysts. This maid of mine have dysmenorrhea every month. She has chocolate cysts, 2 chocolate cysts. What happened was that the surgeon closed the wound after appendectomy and sent her home and wait for 2 months, and she has to come back to see the OB/GYN and has another operation to remove the chocolate cyst. If she were treated at my previous rural hospital, within half an hour, both her appendix and her 2 chocolate cysts will be removed without CT scanner, without any delay in suffering. This explosion of technology creates a situation we call high-tech and low-touch. You use a lot of technologies, but you spend little time with the patient. asking questions, talking to the patient, and do physical examination. And specialization divided the role of doctors. It means that instead of one surgeon who can remove both appendix and shock gastritis, you need two surgeons. The demand increased. Instead of one surgery with one anesthesia, you need two surgery with two anesthesias. You see the burden of increase in demand. Of course, we have to fully understand that doctors are trained differently and they don't want to get involved in things that they are not familiar with. They are doing the best according to what they think. They are doing the best for their patient. But it means that the patient will be diagnosed late and double surgery instead of early diagnosis and just one surgery. So you can see quality of care improve or not, we don't know. We hope that quality of care improve. For example, if you have laparoscopic cholecystectomy or laparoscopic or video-assisted thoracic surgery, you have smaller wound, or even laparoscopic nephrectomy, nephrorectomy, you have smaller wound. You can recover fast. This is clearly increase in quality of services. But in the case that I mentioned to you, the quality of service may not be increases. So you have increasing demand, questionable increase in quality of services, investment, and also the gap between the understanding of the people and the healthcare services. So I would like to summarize in the first presentation 3 tsunamis that affect healthcare system. Explosion of technologies, socio-economic and political change, chronic condition, and mental health, the trend toward that direction. All these 3 increase demand for health services, affect quality of health services both in positive and negative way, affect investment in health services, challenges on us how to be most cost effective with increasing money spent, and challenges on us on the health equity when the poor cannot have access to good or high or new health technology, but the rich has unlimited access. The gap between the society increase and increase and increase. These 3 tsunamis and their 4 effects on healthcare system will have further implications on human resource for health. This is my first topic. Now come to the second topic, which is the implication on human resource for health. If you look into your countries now, you can see that you don't have only doctors, nurses, pharmacists, dentists anymore. You have more health professions. You have medical technologists, you have radiologists, you have physical therapists. Now, physical therapists is very, very much increase in demand due to aging, due to disabilities. Now you have others like audiologists, speech therapists, many other health professionals. But we still cannot forget community health workers. So the first challenge to human resource for health is the skill mix. What would be the best skill mix for human resource for health for your country, taking into account these changes in demand on health services? The other challenge is the mix between doctors and other health professionals, for example, doctors and nurses. If you look into the ASEAN country, Most ASEAN countries will have one doctor for more than 3 nurses. This is quite okay, quite healthy. If you have less than that, one doctor for less than 3 nurses, or some country not in ASEAN has more doctors than nurses, you are in trouble. Why? Because you are training doctors to do the work of nurses. Or you have to use untrained health personnel to do the work of nurses instead. Country like Vietnam, their doctor and nurse ratio are almost 1:1. If you go to Bangladesh, they have more doctors than nurses. If you go to Malaysia, one doctor for less than 3 nurses. These countries are in shortage of nurses, and they have problem because high school students doesn't want to study nurses. They feel that nurses profession is low. But in Thailand, nurses profession is very high. We have a senior nurse who become the vice speaker of the Senate. We never have a doctor who becomes the vice speaker or speaker of a Senate before. So we should respect them. We should respect equal partnership among health workers. And this will affect the next issue that we are going to talk about, which is transformative education, interprofessional education. We need to work in team. Okay? The first challenge, skill mix and teamwork. The second challenge is the shortage, maldistribution, and retention of health workers, particularly nurses in developed country or at least in Thailand. Nurses their working life have been shortened and shortened. They used to work after graduate, maybe 36 to 40 years. Now it reduced to just above 20 years. They leave the profession much faster. What does this mean? This means a loss, big loss, that you have to produce new cadres, new nurses, new graduates to compensate for the big loss. If you don't produce enough, you will face the issue of shortage. Many countries have shortage within the country, but try to export at the same time. You look at countries like Philippines, Indonesia, they are exporting nurses, they are exporting doctors. But if you go to their rural area, they have shortage of this personnel. Retention is the big issue. How can you retain them in the country? We have countries like Brunei, Singapore, and Malaysia who import health workers from other ASEAN countries and even from other countries in other regions. We have exporting countries like Indonesia, Philippines, even Myanmar, who are in shortage. Shortage doesn't mean that you will not export, because workers can move everywhere if they can pass the test and if they have the license. So shortage and retention and distribution is a big challenge. Urban-rural distribution among general practitioner, specialization, distribution among public and private. These are all big challenges for each country. With the rapid economic growth, people prefer more the private services. So the private sector drains human resources from public sector. This is an example in Thailand. In mid-1990s, we lost huge amount of doctors and nurses to the private sector because of the double-digit economic growth. When economic crisis hit in 1997, there was a reverse brain drain from the private sector to the public sector. So for us in Thailand, we like, in health sector Thailand, we like economic crisis. Every time that we have economic crisis, the health sector improved. After the 1997 economic crisis, not only the reverse brain drain that we saw, but we also have the first universal health coverage in the year 2000, only 3 years after the economic crisis, actually less than 3 years. So we are expecting the next economic crisis so that we have opportunity to improve our healthcare system and human resource for health. Now, with the changing demand, changing socio-economic demand, human resource for health must be able to respond to the changing demand. Are we train our workers to be responsive to the new demand of the healthcare system and the community? We are still training our health workers in the conventional way. The conservative field force among health professional education schools are so big that our health professionals started to be less and less responsive to changing demand of the healthcare system and the community. And the final challenges to the human resource for health is the gap between the relationship between health professional and people. Formerly, the relationship is a vertical one. The patient respects health profession like gods. Vertical relationship, also called patron-client relationship. Then, when economic growth, with more expense from the people to pay for health services, they feel that health profession has a contract with them to deliver good services. So the relationship starts to change from vertical relationship to contractual relationship. And you see more demand, more complaint, and more legal actions against providers, particularly when you have health insurance and private sector health services. What we want, which is a big challenge, is to move from contractual relationship to so-called communitarian relationship, where doctors and people are like the people living in the same community. They are like friends. They are like good friends. So when patients go to see the doctor, they have a feeling that I come to see my friend, not a doctor whom I don't know. And when he or she refer me to other doctor, he or she is referring to his or her friends, which is also my friend. Trust is the most important. And trust varies inversely with self-interest. With trade and health become commodities. So health service become commodities for sale. Self-interest is very high. When self-interest is high, trust declines. How can we control the self-interest to maintain the trust among health workers, among the people to health workers? This is the last challenges. So in summary, 4 challenges for health, human resource for health: skill mix, shortage, retention, distribution, response to increasing, changing social demand, and trust building to reduce the gap of relationship between patients and health professionals. Now the third topic of my presentation. What are the movements, the current movements, to tackle the 4 challenges? I'll go one by one. As far as I think it's important movements. Of course, there are many other movements. The first one is the movements on transformative education on human resource for health. This is a movement after 100 years after Flexner report. We have a global commission report led by Julio Frenk and Lincoln Chen in 2010, proposing a transformative health professional education for the 21st century, mainly to address the issue that our current education system does not produce health workforce that is responsive to changing demand of healthcare system and the community. We are still silo-based. not interprofessional. While in the field, they have to work together. But in the school, they are separated. IT, now IT is everywhere. Patients are using IT. How are we going to use IT to support our health professional education, make the education more efficient? How are we going to improve faculties, to develop our faculties members, to be able to cope with the challenging demand of the healthcare system? How are we going to collaborate between the public, private sector, schools, between the users, private users, public health system user, communities, and professional education schools, so that the schools understand the demand of the users? These are all the challenges that we need to tackle under the title of Transformative Education for Human Resource for Health. And there are several movements on this. We have Regional Committee resolution. We have the World Health Assembly resolution. The issue was discussed at the Health Assembly and there was a resolution. And the WHO has produced a guidelines for transformative education since 2013-2014. And in this region, there's an Asian network on health professional education reform. They start to work together. And they also move their works into the so-called AAAH, which I'll tell you later on. The other movement is the movement to retain health workers, particularly doctors, in the rural area. We call rural retention. These are particularly for those ASEAN countries which still have big population in the remote rural areas. Only a few countries where this problem may not be big challenges, like Brunei and Singapore, and to a lesser extent Malaysia. But all other ASEAN countries all have the challenge of retention of health workers in the rural area. So we work together under AAAH, under WHO, to learn from each other on the retention measures to retain health workers in the rural area, which include education measures, rural recruitment, local training, and hometown placement. This is the most important education measures so that health workers are selected from the rural area, trained in the local setting, and they go back home to work there. One good example is the CPERT and ODOT program in Thailand. The CPERT, so-called collaborative project to increase production of rural doctors, recruit rural students and use provincial hospital as school for clinical years and send them back to the province. Then we went further to the ODOT, one district, one doctor program, where we recruit medical students from the rural district, which is from 20,000 to 50,000 population. Rural district, not very good grade student, but we try. And we train them in the local provincial hospital. And they will be sent back home to the rural district. We use motivation, role models, social recognitions to motivate them to work in rural area. Our oldest medical school, Siriraj Hospital, since 40 years ago, give annual award for outstanding rural doctors. The recognized doctor will be invited to deliver keynote address to the professors and the medical students in the oldest medical school to inspire the students and the professors. almost every country now have some kind of compulsory public work so that doctors, nurses, and other health professions has to work for a few years in the public sector, mostly in the rural area. Continuing education, working environments, all needed, including financial incentives. In my country now, if you are a new medical graduate and you agree to work in the remotest rural area, border area, mountainous area, in 1 month, you can earn more than the salary of a Director General or Permanent Secretary in the Central Ministry of Health Office. This help distribution of rural health personnel. So nurses, dentists, pharmacists, public health profession work in rural area all have this kind of social recognition and financial incentives. So these are the things that we need to establish in order to ensure rural retention. WHO has produced recommendation, a book for the recommendation for measures that can help developing countries to retain workers in the rural area. Now, private sector have increasing roles in providing services as well as in producing health workers, health professionals. You look at Philippines, most medical schools are in the private sector. Private medical schools are started to emerge in ASEAN countries. The concern is how to ensure their quality, competency, and spirits of health profession to help the people, not to be commercialized, too much commercialized, and aim at trading for health services to get money. But the priority is to serve the people, to solve the health problem. No matter you graduate from public sector school or private sector school, how can we maintain this spirit in light of the increasing private educational school in this region of the world? If you go to South Asia, you see mushrooming, not emerging, but mushrooming of private medical schools without good quality control and produce so many medical doctors. Many of them exported or do something else which is not medical services. If you go to Mexico, you see that only two-thirds of medical students graduates, and only two-thirds of medical graduates practice medicine. This is a big loss, educational loss, which we don't want. So we need to have a good mix of private and public sector role in order to ensure most efficient use of limited resources. Now, within the region, there are so many collaboration, particularly under the trade agreement, under the ASEAN community, economic community. We have an agreement called ASEAN Framework Agreement on Services. And under this framework, we have so-called mutual recognition arrangements. There are 8 professions that we have signed the mutual recognition arrangement now. For health, we have medical profession, nurses, dentists, and I think pharmacists is coming soon. This mutual recognition arrangement create misunderstanding among people that, after we sign this mutual recognition arrangement, doctor can move from one country in the 10 countries everywhere they want. Nurses, pharmacists, dentists, the same. But in fact, nothing changed, I can say. Nothing changed. So we don't have to concern that much. The only change is that the health professional bodies, like medical council, nursing council, of these 10 countries who never talk to each other, now start to talk to each other, now start to share their standards their qualification standard, their accreditation system, so that one day when they achieve same standard, they can really mutually recognize. Of course, it may start with a few countries like Singapore, Malaysia, in Thailand, more advanced country. They may start to mutually recognize. But within the next 10 years, I don't think there will be real mutual recognition. Of course, there will be unilateral recognition. Country like Singapore go out to other ASEAN countries and recognize a few medical schools which they think are the best, and then allow medical graduates from those schools to come to work in Singapore with much less limitation. And they can stop anytime. Okay? Now, the last point of the measures, which is the most important point. In order to do all the 4 points above that I mentioned, education reform, transformative education, rural retention, public-private mix, and work under trade agreements. You need to have capacity to lead, to govern your healthcare system, capacity to generate country-specific evidence to support your decision how to retain health workers in your country, how to train, how to transform health professional education in your own country. This is the most important measures. So we create a network, actually many networks. One of the networks is AAAH, Asia Pacific Action Alliance on Human Resource for Health, with 7 countries working together to build up, to strengthen the capacity on health policy, health system research, and research on human resource for health in order to generate evidence to inform policy decision and take action, assess the actions, and reformulate the policy. The AAAH network meet previously every 1 year. Now we meet every 2 years to exchange our experience and evidence. Between the 2 years, we have so-called intersessional activities, which include joint research on certain topics like transformative education, rural retention, role of private sectors. This intersessional work will be fed into the biennial conference for sharing of experience and will be used to move policy regionally and within the country. AAAH has now 17 member states. 17 member states. We don't have big funding from anywhere. We have to fund ourselves. And we keep very small secretariat. We have ASEAN Plus 3 Universal Health Coverage Network under ASEAN umbrella in order for 10 ASEAN countries to work together on universal health coverage. Universal health coverage is a big policy. Most ASEAN countries now achieve or nearly achieve universal health coverage. Only Myanmar, Laos, and Cambodia still do not have clear commitment to universal health coverage. The rest are all covered. 3 countries, Philippines, Indonesia, and Vietnam are about to achieve in the next few years. Okay? These are the measures that we have so far on human resource for health. Last one, sorry, I missed that. The World Health Organization last May has just approved a 2030 global strategy on human resource for health, which include all the issues that I mentioned. So this is a global movement which will bring into the regional movement to improve human resource for health within our region. Now we move to the last part, which will be only 3-4 minutes. 4 key success factors to deal with, to get a good and appropriate human resource for health in your country. First, you need to have to build continuity of leadership from all walks of life. You need champions who don't stop to work on human resource for health among the people, community, professional education, health policy, health system, research, and leaders. They need to work together. Second, you need to build capacity. Individual, institutes, and network of institutes of individuals who do research on health policy and health system and human resource for health, like the AAAH. Third, you need to have strong social and community and political commitments to improve health system based on primary health care, based on Sustainable Development Goal 3.8, which means universal health coverage. Once you have universal health coverage, it means that everyone will have equitable access to health services and human resource for health. It will ensure good quality human resource for health. And lastly, you need a good monitoring and evaluation system, information system, to monitor your human resource for health strategy. These are the 4 key success factors. Now, in summary, what I have talked to you today is about ASEAN. You know, ASEAN is the so-called microcosm of the world. It's like a small world. You have from small to big country, from less than 1 million to more than 250 million people. You have from poor, low-income country to high-income country. You have all the religion. You have all form of political governing political system, economic system. So if we can agree anything here, you can agree everywhere in the world. ASEAN is a big challenge, but we try to work together. Okay, I talked to you about 3 big tsunamis that hit healthcare system. 4 challenges to the healthcare system, 4 challenges to the human resource for health, and all the measures in this region. Now, if I want to say the last word, what do I want to say? I would say that the heart and the spirit of the health workers is the most important factor for the success. How can we build this heart and the spirit of health workers to work for the people, to work with the people interest? In Thailand, we are lucky. We have the father of modern medicine and public health in Thailand, Prince Mahidol, whom we all love and respect. His Royal Highness taught us 3 mottos. First, he said, I don't want you to be only a doctor, but I also want you to be a man. Always remember that you are a human being. Treat your patient as a human being, not as a doctor. Treat the patient. Treat the patient like your relatives, your friends. Second, true success is not in learning, but in its application to the benefit of mankind. So when you graduate as a doctor, as a nurse, you have graduate to succeed in learning. You may be first grade, first degree honor, but your true success is how you use your knowledge to deliver good services to the people. And the last motto, put public interest as first priority. Maintain your professional ethic, and you lead a good and prosperous life. Every Thai health professional remember all these 3 mottos in head. Not all of them implemented it, but at least they have these 3 mottos in their heads, and they are equipped more or less with spirit and heart for the people. Reduce their self-interest and creates the best trust, the highest trust among the people. And that is the human resource for health for universal health coverage. I thank you so much, and once again, please accept my sincere apology for not being able to be with you today. Thank you.